welcome to the 2019 Herman A. Tyroler Distinguished Alumni Award and Seminar. This was established in 1996 with the help of the Alumni chapter of the Gillings School of Global Public Health. A few words about Tyroler, but I realized that we actually have in the room our speaker who knew him, contrary to me. So I would encourage you to look up the first 40 years of the Department of Epidemiology, which you can find online on our website, which has a really nice overview over the first 40 years of the history of the department, including on Al Tyroler, who was a faculty in the Department of Epidemiology from 1960 to 1999, so 40 years. He had a transformative influence on the field, and he was also an architect of cardiovascular disease epidemiology. His understanding of and enthusiasm for epidemiology, coupled with his desire to tackle major public health issues, led to his long-standing influence on the field and on public health. He was also a notable teacher and mentor, and we therefore celebrate Al Tyroler's life and influence on the field and the Department of Epidemiology with this annual event. And we also want to honor one of our outstanding students in his name with the Marilyn and Al Tyroler Scholarship today, and I would like to ask Shahar Shmuel to come up here, who is the recipient. Department chapter leader, and who couldn't be here today, and it would have been his honor to introduce David Ballard, MD, MSPH, PhD, and fellow of the American College of Physicians. It's a long CV, 50 pages long, so I'm going to try to condense it into the major points. He got his MD from the University of North Carolina School of Medicine in '83, and his MSPH and PhD from the Department of Epidemiology at the University of North Carolina School of Public Health in '83 and 1990 respectively. He did his residency in internal medicine at the Mayo Clinic in Rochester, Minnesota, and got various certificates, medical license in '84, American Board of Internal Medicine in '86, and medical license in the Commonwealth of Virginia in '92. He is currently on the board of directors of Mentis AB, the world's leading provider of endovascular clinical simulation performance solutions, and I'm pretty sure he will tell us more about this. Prior to that, he was the Senior Vice President Chief Quality Officer of Baylor Scott & White Health in Texas, the President of STEEEP Global Institute, Baylor Scott & White Health, the President of STEEEP Global Institute, Baylor Healthcare System before that, and Senior Vice President and Chief Quality Officer at Baylor Healthcare Systems in Dallas, in Texas. And again, I'm abbreviating here a lot. He has multiple honors, including he was the recipient of the Academy Health New Investigator Award in 1995, given annually to the Outstanding Health Services Research Scholar in the U.S. Less than 40 years of age. In 2012, he was the recipient of the Joan M. Eisenberg Article of the Year in Health Services Research, and in 2008, he received the Distinguished Alumnus Award of the University of North Carolina School of Medicine. So, without further ado, please welcome Dr. David Ballard. Now I have to unpack this thing here. And I was told to leave the paper in, I might need it, so I'll leave the paper in, and I should probably move over here, and this is the way it should go.
Okay, better pictures later.
Thank you. Very good. So Chandra's, I know, organized my life here for this visit to Chapel Hill. And so just to kind of update us on the time, your guidance here around how many minutes of comments and how many minutes for discussion?
Let's see how you do by 4:30 then. Yeah. Let's see how you do by 4:30. Now you have a game to get to.
So you would like me to have roughly 50 minutes of comments?
Well, no, not roughly, let's just see how the move takes us, but yes.
Okay.
Yes, just look to me, I'll get you a number, yeah.
Very good, great. Well, it's a pleasure to be here with you today. In a minute, I'll get into sort of one of the ways that you qualify, I guess, to receive this award. You have to be a UNC alumnus, and so I'll talk about how I became a UNC alumnus. But one of the things that I did want to share with you, so I'm currently doing an MBA, the MBA at UNC. Is anyone here doing an MBA, or has anyone done an MBA here? Tonight I have from 9 to 11 a synchronous class related to business communication. And I've been told going into that class that only 7% of the impact of a presentation relates to the content. When we have our synchronous session, I'm going to challenge the instructor tonight and say, probably relates to like the audience. So, for example, like if I was going to show you some hazard ratios in those Kaplan-Meier survival curves crossed, or if I was going to show you, a logistic regression result and try to make you believe that that represented a relative risk in the endpoint of interest happening 50% of the time, you might sort of scratch your head about, whether my content was adequate. So, but having said that, I actually learned a lot this week from my business communications asynchronous course about how to put a different approach to bringing some of these slides together, and I hope you'll find that to be engaging and of interest, and maybe you might be motivated to take the business communication course. So I was told don't use bullets, use images. So what we're going to do, we're going to talk about how I became a target, talk a little bit about Al Tyroler, in particular my relationship with him. And then we're going to talk about STEEEP care, triple aim, transitioning to the quadruple aim. Ed Wagner is probably the person most responsible for the transition from triple aim to quadruple aim. We'll talk about that. And then I want to thank a lot of folks. I certainly want to thank you for carving the time out of your day to be here. So how did I become a Tar Heel, which is one of the prerequisites to be able to receive an award like this? So it started with 8 points in 17 seconds. So was anyone else at this game? So I'm a senior at the Lawrenceville School. I get nominated for the Moorhead. I have likelies from Harvard, Yale, and Amherst, the 3 schools I applied to. And they said, Dave, would you like to look at this scholarship? Nobody from Lawrenceville's taken it in 5 years. I said, I'm from the South, and my father by that time had developed Parkinson's disease. And I knew he was going to have a tough time sending me to college. But he had been a surgeon, and I was going to have a difficult time qualifying for financial aid immediately. And so I said, sure, I'll go take a look. And so the morning of my 18th birthday, March 2nd, 1974, I interviewed for the Moorhead Scholarship. Amongst the things in that interview was kind of interesting. One of the folks who interviewed me said, well, Dave, would you like to be head of the WHO someday? I said, no, actually, I'm really interested in leading healthcare systems and engaging healthcare delivery a little more directly. A little bit later in my undergraduate career, I was a North Carolina fellow. Anyone here, an NC fellow here? So when I was a North Carolina fellow, we had a really intimate group of 13 students per class, leadership development program, and one of my dear friends, Mary Friday, Bill Friday's daughter, Mary Friday Ledbetter today, she was one of the 13 fellows with me. When I finish this, I'm going to walk over to her home where she's having a Democratic fundraiser. But anyway, so Mary and I spent a week at the Center for Creative Leadership in Greensboro as undergraduates. And once I went through all the head shrinking and folks looking behind a mirror, the guy looks at my profile, the CEO of the Center for Creative Leadership again, says, David, you really should become a university president. I said, no, I want to lead healthcare systems. And so anyway, so the second kind of major event that related to me deciding, ultimately ended up in this department. So a disappointing day in May 1978. Anyone here studied economics at UNC? No. So I was defending my undergraduate honors thesis. I thought it was a great thesis. My advisor thought it was a great thesis. And turns out I actually had the only undergraduate thesis that was published in a peer-reviewed journal. It was published in the Eastern Economics Journal, that if you wanted tenure in those days, it was a pretty good place to publish. And I got an honors rather than a high honors for my work in economics. But more importantly, my advisor, who was one of the world's most distinguished health economists, today is, and at that point was one of the most promising health economists, he didn't get tenure. They made a decision that day not to give him tenure. So he transitioned to become an endowed professor somewhere else, and there were no health economists left. I was planning on doing a PhD in economics while also going to medical school here. So I was fortunate. I had met Ed Wagner as an undergraduate. So two people connected to this department, Gene Mayer and Sam Putnam, in the spring of 1975, they had an undergraduate honors program seminar series where we met in their homes. And they brought in the leading lights. They brought in people like Cecil Sheps. They brought Carr White through. And Ed Wagner was part of the list of luminaries who would come and spend an evening with us. So I had met Ed, and when it was clear that I wasn't going to be able to do medicine and economics, Ed reached out to me and said, David, if you still want to go to medical school here, there's no defined program, but I understand what you want to do with your life, and we'll put something together that allows you to do that. So this was 1978. There was no combined degree program, no MD, PhD to do something in the School of Public Health. I was the only person out of 160 people in my medical school class to do anything in the School of Public Health. And my colleagues sort of asked, Dave, what are you doing walking across the street there? What does that have to do with a career in medicine? We don't understand what this is all about. So over 5 years, so I did the first 3 years of medical school. At that time, the first 2 years were basic science. The third year was clinical. The fourth year, you had to do 7 one-month clerkships. And so I did, what I did over the next 2 years, my fourth and fifth year, if you will, as a graduate student, I did all the coursework and all the exams for a master's and PhD, including the doctoral exams. And I did the 7 one-month electives. So I left here at Chapel Hill in June of 1983, all but dissertation. But I still hadn't finished my doctoral degree, so I still didn't qualify for being here today. And maybe just one comment about this is ancient history, but in 1983, what we actually had for our doctoral qualifying exam, we were given a list of, I think it was 4 or 5 questions. And you could select one of those questions, and you had a week to write an NIH grant addressing those questions. That was an incredibly useful stress test early in my career. It turned out I was really gifted in being able to generate peer review funding early in my career, and that was probably much more useful than a knockdown, drag out, multiple choice essay kind of doctoral exam. So I left Chapel Hill in June 1983. So I survived eight winters in Rochester, Minnesota. I went there to train in internal medicine. I joined the staff, so I may have been one of the few people who was an associate professor before finishing a doctoral degree in epidemiology. I was a consultant, and I led what was called the Section of Health Services Evaluation at Mayo. And I wrote grants nights and weekends as a medicine resident to fund my dissertation. This is ancient history, but the precursor to the precursor of ARC, something called the National Center for Health Services Research. So there were 54 applications for a doctoral dissertation award in 1984, and I was fortunate to receive one of the 2 that were awarded amongst those 54 applications. So that grant and a couple of other grants funded my dissertation, and I completed my dissertation in towards the end of 1990. I think my degree is maybe December 1990. So that sort of established my Tar Heel status. And so, I've been there before as an undergraduate. I think I was there with Lawrence Taylor, and I've been there with 4 times now, and look forward to being there with my MBA as well. So Al Tyroler, and this is really about Al Tyroler, and I'm just fortunate to be someone who can be here today and talk to you a little bit about Dr. Tyroler's life. So who knows about the Evans County study? Anyone else know about that? So the Evans County study, Evans County, Georgia, Claxton, Georgia, what, over 1,000 papers probably come from Evans County. So I was taking a undergraduate medical sociology. Do we have any sociologists here? So I was taking a class from Robert Wilson. Robert Wilson was a esteemed medical sociologist, poet. He was one of Talcott Parsons' students. Talcott Parsons was legendary sociologist at Harvard. So Dr. Wilson addressed our class the day after John Castle died, and he talked about Castle's legacy. But part of what he talked about was the Evans County study and the UNC decision to participate in that. And he talked about how there were people at the university, including Dr. Wilson, who had concerns about the university being involved with the Evans County study because the waiting rooms there in the clinic site were racially segregated. And there were concerns about whether UNC really wanted to be involved with this. But there were other people who thought that this research could ultimately lead to reducing disparities in health status. And so Bernie Greenberg, John Castle, and Al Tyroler were people who were on the side of feeling that UNC should in fact accept the invitation to work with Dr. Hames and launch the Evans County study. And so that's kind of the first time I heard about Dr. Tyroler was in that medical sociology class, I believe the fall of 1976. So anyone here thinking about a master's thesis topic, or you're all beyond that? So some of you are maybe thinking about it. Okay, so I was taking a cardiovascular epidemiology class from Dr. Tyroler. And, you know, Ed Wagner is sort of in the background, Ed ran the Robert Johnson Clinical Scholars Program. He was really my mentor and my MD, Master's, PhD advisor. So there was the community part of the community survey part, random household survey part, you know, led by folks like Sherman James. Michelle Ibrahim was the overall PI of the Edgecombe County study. And then there was this community clinic assessment piece to look at hypertension processes and outcomes. And that was really what Ed Wagner was leading. And I was fortunate to have the opportunity to work with Ed on that. So, you know, you get into these methods and you can think about, well, you know, there's probably all sorts of interesting things you might do methodologically. And so I thought, well, look, okay, we have this community, Edgecombe County, where you have this random household survey. Well, what if you actually looked at people in the clinic and stratified them or classified them based on whether or not they participated in this survey? And you looked at before and after the survey period and asked the question, did exposure to the survey actually influence their blood pressure levels, or did it influence other health status factors? Now, you know, again, you probably have had some of these mind games in your experiences here. I thought it was kind of interesting. I talked to Dr. Tyroler about it. He was absolutely ecstatic about this as a possible master's thesis. So, and why? So Dr. Tyroler knew everyone in the world in cardiovascular epidemiology. And one of his colleagues was Igor Glazunov, who had spent some time in Chapel Hill as well. And I actually hadn't read Igor's paper at the time, but when Dr. Tyroler heard about my interest in this, it was part of I think we had to propose some research project as part of the cardiovascular course. He said, David, you know, my dear friend Igor has looked at this issue. And so it's a much longer story, but Dr. Glazunov showed that cardiovascular disease risk factors were substantially lowered amongst people who had just been exposed to repetitive health exams without any specific other healthcare interventions. So Dr. Tyroler thought that it would be really important methodologically for the field of cardiovascular research to determine whether such effects might have played out related to the Edgecombe County household survey. Now, Ed Wagner, who while also very interested in methods, Ed has, one of his gifts is understanding the big picture as well. He said, you know, David, what we're really all about here is to try to understand processes and outcomes of care in that clinic. And, you know, I know that Dr. Tyroler loves your idea, and I know that he wants to give you some research assistance to pursue it. But, you know, we're really not interested in that because we think it's going to detract from our focus in the community. So what finally happened then was I decided that I would put that on the shelf, and to the extent the Edgecombe County data set still exists, that would be a great master's thesis. So I was thinking about it. So let's move on to the topic of STEEEP care, the triple aim of healthcare, and also we're going to talk about the quadruple aim. So how many folks are familiar with the Quality of Care in America series of the Institute of Medicine? Anyone read any of these books? So the first one was To Err is Human in 1999. The second one was Crossing the Quality Chasm. So in Crossing the Quality Chasm, this came out in 2001. They articulated 6 aims for quality for America. And around that time, so I moved So initially, my career after UNC, I went to the Mayo Clinic. I left Mayo in 1991 with my wife, an Italian citizen radiopsychologist. We went to the University of Virginia, and I developed a health policy institute there that focused on transforming Medicare quality methods. And then I moved that institute as a 501c3 public charity from Virginia to Georgia, where I was a professor of medicine and epidemiology at Emory University. And at Emory, worked closely with Ray Greenberg, who graduated the school, who was the founding dean of the School of Public Health at Emory. So in '99, I was recruited to Baylor to be the Baylor healthcare system in Dallas to be the first chief quality officer for Baylor. The second quality officer in the United States, Brent James, started at Intermountain Healthcare in 1992 in his role as chief quality officer there. So as I was beginning to think about bringing together an approach to healthcare quality improvement for Baylor healthcare system in the Dallas, Fort Worth metropolitan area, this book was just coming out. And these 6 aims were identified by the Institute of Medicine. That care should be safe, timely, effective, efficient, equitable, and patient-centered. Now, if you go back and actually read the book, you'll see that there was what I characterize as kind of a strange arrangement of those words into an acronym that was something like STEEPE or something that no one could ever remember what that acronym was. And so, I was in this role of trying to figure out how am I going to engage this very large healthcare system in Texas, 1999, 2000, with 25,000 employees. How could I communicate to them what we were trying to do? And so I thought about those 6 words, and I said, how can we take those 6 words, come up with an acronym that might be something that someone could remember? And so I ended up aligning those words into the acronym STEEEP, safe, timely, effective, efficient, equitable, and patient-centered. And one of the things I did was I trademarked STEEEP as well, because I wanted to make sure that it was clear across our organization that this was sort of our true north, our mantra for improving healthcare. So while the Institute of Medicine was beginning to engage this national agenda around these 6 aims for quality, Donald Berwick had a paper in Health Affairs sometime around 2008 that sort of framed up what was called the triple aim of healthcare related to reducing population level healthcare cost, optimizing population level healthcare outcomes, and improving the patient experience. Ed Wagner and colleagues at Group Health had been working on initiatives that certainly align with those 3 aims. And what they found was that the nurses and physicians and other care providers at Group Health had a lot of stress related to their professional lives, had a lot of hassles related to care delivery, and Ed recognized that you actually needed to work on caregiver joy and caregiving to actually make progress on those other 3 aims. So out of that, then became the quadruple aim of healthcare. So better health outcomes, improved patient experience, lower cost, but improved physician, nurse, other staff, including non-clinician administrator experience with care. Is anyone doing any work related to caregiver experience? So, among some of the observations, 400 physicians commit suicide every year in the United States. That's probably almost a couple of medical school classes here at UNC. I've certainly been involved with reviewing manuscripts in the literature in my editorial work where the nurses taking care of the patients in many instances had worse health status and worse reported health-related quality of life than the patients they were taking care of in the hospital. So I just want to walk through work kind of related to this whole agenda of care that's safe, timely, effective, efficient, equitable, and patient-centered, and work that endeavors to reduce the cost of care, improve health outcomes, improve patient experience, and improve joy in caregiving. So my first experience was actually predated my school of public health. I had finished my undergraduate thesis in economics, kind of on its way to getting published. And I was a little bored. I was going to start medical school in this, end of the summer. And so I was around December or so. So Sam Putnam, who I had met as a freshman, Sam co-chaired the Utilization Review Committee of North Carolina Memorial Hospital with another internist who also had an appointment in epidemiology, as did Sam. They co-chaired this committee. So they asked me to develop this appropriateness of care tool to be applied to admissions to try to determine whether there was a significant problem with inappropriate admissions. And so, what did I learn from that? One of the things we found out was that of the hospital admissions we were seeking to classify, we could find that the hospital medical records on only half the patients who were on the list we were looking for. The other thing I found was that of the patients who were listed, most of them had 2 or 3 and 4 medical records. I think someone had 7 different medical record numbers. The other thing I learned from that was, I was doing my diligence, going through the records, applying this instrument to the records, and Sam and Vern were supposed to also do that. And long before Haya Rubin's 1991 paper showing how bad physicians are in assessing quality through review of medical records, Sam and Vern I think they only did about 40% of the charts they were supposed to do. They didn't agree with one another at all. And needless to say, while there was a final report for the Utilization Review Committee, this didn't end up like my undergraduate honors thesis. It didn't end up in the peer-reviewed literature. But I learned a lot from it. So my master's thesis, it could have been the Igor Glazunov master's thesis co-authored with Al Tyroler, and I would have loved to have done that. But this work was also very important. Michelle Ibrahim was the overall PI on all this work. This was funded by the National Heart, Lung, and Blood Institute. We had all these Davids involved with this work. We had David Ballard, David Strogatz, who I believe nominated me for this award,